All right. Well, hey, welcome. It's a pleasure to have you here with us today, and I am honored to be down here in Tuxtla Gutierrez. It's an area down south in Mexico, and this lab is Dr. Antonio Munoz's lab, and this awesome vascular surgeon friend of mine also has allowed us to come in here and record for you an experience in VR of what a transpedal intervention means. I'd like you to look a little bit here at the foot that I have. We've washed this and decontaminated as much as possible. As you can see, there's a pretty severe situation that this patient had a plantar abscess. Remember, step one is always in chronic limb-threatening ischemia to take care of the infection. But on non-invasives, it's evident that this patient has severe distal pedal, not necessarily pedal, but certainly tibial disease. And so what I'm going to do here to try to keep the area as clean as possible is I'm just going to wrap it up here in one of these nice towels, and we like to pull the foot a little bit medially. You want that foot to rotate because the natural thing is feet tend to kind of lay on their lateral side. You want to rotate it a little bit so it's easier for you to do that. Second, notice that I'm sitting down. As you get better at doing this, sitting down helps a lot. Your shoulders are relaxed, your back is in the right position. Trust me, when you do this many years, there's a lot of parts of your body that start hurting. So anyway, this is an ultrasound we're going to be using today. This is a sonocyte with a nice linear small probe, which is, I would say, perfect for this sort of axis. And I'm going to show you here what on the screen we see. So in your VR, I would like to invite you right now to look at that screen, and you can either double click it or open it or make it wider so you can look at the ultrasound. And this is certainly a very nice view of the distal anterior tibial. On duplex, this patient has evidence of a normal triphasic waveforms down to the popliteal artery. And then from the pop down, there's a significant amount of occlusions and stenoses of hemodynamic significance. And based on the waveforms, we have selected that the anterior tibial is probably our vessel to target because there seems to be it seems to be the best vessel that we have going on from the knee down. And based on the arch, we may or may not attempt anything else, but I believe that today what we're trying to do is get better perfusion into the top and the anterior part of the foot, and hopefully if the arch is intact, that AT will actually curl under the foot and give us better perfusion for that bottom of the foot. So anyway, this is a transversal view. When you compress, you can see very easily those are the two anterior tibial veins. And in the middle, you have that beautiful, juicy anterior tibial artery. And this is right at the transition between the AT, and I go down a little bit more, and that's probably the DP. And I'm going to go longitudinal to see the texture of the wall, to see what areas are the best areas for me to access. And I also want to be comfortable, okay? A lot of operators have different ways to do this. I'm a personal fan of the longitudinal approach, but a lot of people will advise that you can poke the vessel in a transversal way, and then once you get blood flow, you can turn it to the longitudinal way to see the guide wire. I think you could do both at the same time. So I'm going to go and get a nice image here in the longitudinal form, like that. And then once I get that, and I like what I'm looking at, then I'm going to consider my access needle. So Cook has certainly a great toolbox for this sort of intervention. And what we'll try to do today is we'll try to do this whole intervention from the bottom up. That is going to limit our access site. And particularly in this patient, there has been a fresh previous surgery up in the groin, and so if we can get it all done from the bottom, it makes sense. And then obviously there are going to be a lot of other indications, like patients with complex habitus or such. Oye, Dani, las luces están como en blinking. ¿Eso quiere decir que todavía está funcionando? Daniel.
¿Todo va bien?
Es que pasó de estar full a estar en blinking. Alright, so anyway, I'm going to walk you through the access site. So I have the micro needle, and I'm going to put it right next to this probe. The idea here is if I can try to identify the needle on the top part of the screen. Now, because I'm coming from the bottom up, you should be able to see that needle on the right hand side of the screen, and I think that that's an appropriate image. We want to try to get that as inline as possible to where you can almost see the bevel. And one thing that I like doing is I tap the wall almost to see if I'm indenting the artery. And if that artery indents in the right spot, then I feel that I'm at the area of the sweet spot. So I'm going to go ahead and push here. I should have a little bit of a pop back. And I did feel that little pop. If you see there, I'm a little bit close to the back wall, so I'm going to back that up a little bit. And I'm looking already, I have nice flow through the through that needle. And now what I'm going to do is I'm going to very softly, I'm going to try to get this wire, and I'm going to torque as I'm going in. The idea here is that we want to see the wire going in through the arterial access site. Alright, so slowly, very slowly. And as you see there, you see the wire torquing. Those reverberations help you know that you're free and that you're in the inside of the lumen, okay? So I'm going to go ahead and torque a little bit faster and advance that wire up. I've got no resistance until I hit a little resistance there. That means I'm probably hitting part of the plaque that we're going to treat today. So I'm going to stop there, and I'm going to try to advance the catheter and sheath, or at least the sheath. So I'm going to do a little nick of the skin here, just to create a little bit more space. Perfect, thank you. And then remember, I'll just show you real quick, the transpedal sheaths come in two parts that have to be inserted. This is just the dilator that helps you place the device, and this is the transpedal sheath. Once the sheath is in place, you actually put a little valve cap in it, and then you're ready to go. So I'm going to put the dilator in, I'm going to take the needle out, and I'm going to advance, needle down, I'm going to advance the sheath. Tiene la válvula. And I'm just going to very slowly advance the sheath. Let me hit what? I know, yeah. Here you see the wire coming in, and what I'm doing is putting that pedal sheath in. You can almost see the pedal sheath as it's kind of hugging that. And so you see how nicely that pedal sheath is going in with very little effort. And now what I'm going to do is I'm going to uncouple, and I'm going to go back to the ultrasound so you can see this. Once I uncouple, I'm going to pull the wire and the dilator out. You'll see the wire come out here shortly. And you can certainly see how well you can see the sheath already in. And now I'm going to focus on placing the small valve. This valve goes in the back. And at that point, we are ready to rock and roll. Some people like to stabilize this with a little plastic adhesive. I think that we'll just be very mindful today and make sure that we do it in the right way. So at this point, you could possibly do a quick angiogram, see what you're working with, and how about we do that? So let's do a quick angiogram. Upward. So we're ready here for a quick angiogram of the foot. Let's see what we're working with. Very sluggish flow, I'm not surprised. But certainly you can see the dominance of the anterior tibial circulation. And vamos para arriba, we're going to go a little bit higher up. And we're let's take a look a little bit higher up. And you have to be careful with how hard you push that contrast, because you will eventually kind of push it into the capillary and into the venous anatomy. So I'm going to go ahead and do that one take again with a little bit less pressure, and hopefully get you a little better understanding of the anatomy. There you go. CTO, small short CTO. Actually, I'll take that small short CTO there in the mid portion. Vamos más arriba. Un poquito más.
Arriba.
Sí, ahí. And let's see the rest of this AT going up. There you go. And you can see also how that venous anatomy is starting to show up, and you shouldn't be concerned that you've done anything wrong. It's just you're forcefully pushing contrast through the capillary system, and because there's a CTO, it goes into the site of least resistance. So I'm not going to use any imaging at this point. I'm going to try to just get a good wire that could traverse all this, and I think we have a Hydro ST. Hydro STs are 014 nicely covered wires that Cook has, and I am going to just create a small tiny 15-degree bend here. And if you are looking through my GoPros, you can probably look at how much I'm putting here. I just use my nails, and that's about a great angle to find the area and traverse it. And we're going to really use that. If you look again at the GoPro, if you see how that wire moves, as it's free, then it moves in the right direction, and it means it's luminal. If it stops wiggling, then it means that maybe we're stuck in an area. So we're going to try to keep it pretty safely inside the vessel. Can I have the CXI? Let's use a, no, actually let's go straight to a balloon. We can use the balloon as a catheter, as a support catheter. So we're going to put the balloon first, and we're going to use a 2mm balloon. And what's nice about these micro 14s is that they actually are compatible with the pedal sheath. So again, go back to the GoPro, and as you see, I'm going to have no trouble whatsoever just inserting this into that proximal segment of the pedal sheath. And then with that there, I'm going to go ahead and insert the Hydro ST, and I'm going to go and set the table in the right spot so we can ascend. All right, so now we have that micro ST. Go ahead and collimate, please, collimate. So we're going to keep that image pretty tight. And as you see, the wire is wiggling very free. I'm going to mag that up real quick for you. Mag, zoom. Lo más posible. And so you see how nicely that wire, this is the sheath, the transpedal sheath. So again, focus your eyes on the screen and see how easy this wiggles. Whenever the wire does this, it means it's in a free space. Whenever the wire stops wiggling and the curvature of the distal tip goes straight, it means you're stuck somewhere, right? So we want to keep that wiggle as we go on. And if you see through the GoPro, this is the wiggle I'm talking about. You're also in front of it. You can look down at my hands. And the idea is you're wiggling away, you're in the right spot. All right. Let's go up. Vamos para arriba. So we're going to go ahead and keep wiggling away. And I'm starting to feel like there's a little bit of a resistance there, but you saw that that wire wiggled through that resistance pretty well. And so I'm going to try to wiggle away this. And now what I'm going to do is I'm going to just advance the balloon a little bit until I catch the balloon here. You'll see here shortly the balloon should be coming in. There you go. And I'm using this balloon as a micro catheter, but with Cook you have also in the toolbox CXI micro catheters that are braided and are phenomenal for this sort of stuff. Sometimes they come in different sizes, 65, 90, and 150. Not sometimes, they do come in those sizes. and I would invite you to have different sizes so that you know exactly what you're getting yourself into. So anyway, you see that I'm still wiggling. I'm going past that, so I probably made it past that CTO, and there's a little bit of a resistance there, but I'm getting still the wiggle, and I'm also looking at the calcium and making sure that I'm still in the right spot when it comes to calcium. The other thing is I'm having no resistance whatsoever getting the balloon into the right spot and advancing it. All right, let's go higher up. Okay, that looks to me as if it's coming out of the vessel, but backing up, store that fluoro. Grábame la fluoro. So focus on the wire. You see how that took a weird turn and almost like hugged the artery? And in this case, and then it stopped wiggling. But then I backed up and then I wiggled again and got it right into the luminal space. So right there it seems like it's out. I'm back into the lumen and I'm now wiggling until the point that I find that wire again wiggling. So I think I was out in the subintimal space and now I'm back in the luminal segment of the artery. So the artery is wiggling nicely and I'm coming up to the point where that anterior tibial should dive into the popliteal artery. So I'm advancing the balloon, and by the way, all this time, zero resistance on my balloon. So knowing anatomy, you should expect that the anterior tibial dives and branches from what the popliteal is. So it's going from the anterior compartment into the posterior compartment of the leg and behind the knee. So let's see if it does as expected, which should be take a quick turn, dive, and then go up into the pop. Beautiful. That's exactly what we wanted. And now I'm actually going to come all the way up with my balloon and stay there, no te muevas. And now, because we're all the way up and down, I'm actually going to remove the wire and I'm going to give the wire back to the team, and I'm going to use the balloon as a catheter so I can still use this port, and I'm going to do an angiogram through that port, okay? And that way we will make sure that we're in the right spot. So the first thing is we're going to suction, of course, and we want to see blood. That means that we're in the right spot and that we're not subintimal or subadventitial. And then, quítale el zoom. Arriba. So now we're going to just get that balloon to the point where we get enough of that image right there. And now I'm going to do a DSA through the balloon and get an understanding of the anatomy that we're working with. So you see the PT is occluded as we knew on the duplex. Perineal has some flow, and then the anterior has sluggish flow because, of course, there's a lot of occlusions distally. Again, we knew this. We don't need a diagnostic angiogram. We have a very good duplex that we're going to use. So I'm going to go ahead and use this image, understanding that I don't need to plasty the proximal segment of the AT, and I'm going to just secure the wire, pull this back, and angioplasty the anterior tibial. So I'm going to pre-dilate first with a smaller balloon. This is going to be a 2mm balloon, and then we're going to go in with a bigger because I think this is a big, juicy anterior tibial. All right, wire's back in place. Now I'm going to pull the balloon. As you saw, the proximal AT was pretty good looking, and it starts hanging somewhere here. So I'm going to vamos para arriba. I'm going to readjust the table here. There you go. So we're going to leave that image there. We're going to pre-dilate with an endofluid. Negativo. Ahora metemos el aire para afuera. I'm just prepping this balloon old-fashioned way, and Dr. Muñoz here is going to slowly start inflating that balloon. And I don't see a huge amount of calcium in this particular artery. So I'm not necessarily under the impression that we need anything aggressive other than a good balloon angioplasty. So we're going to go ahead and do that by using first a 2mm balloon and then going to go up to a 3mm balloon. I think this vessel can easily take probably up to a 3.5mm balloon. But this is a smaller patient, not rare in this area. So we're gonna stick with a 3 for now. So this is a little bit more soft balloon angioplasty of the distal segment. And once we're done with that, we're going to go up with a 3. Alright, negative on that, and we'll make the 3 a little bit longer. This is just a predilation with a shorter balloon, small balloon. Okay. Enséñame la pop. Ok, saca el balón.
¿Está bien?
Sí, está perfecto. No, estamos asegurándonos que la guía no se vaya a ningún lado. Ok, vamos con el 3. Ok, graba. So now we're upsizing. We are now going to take, do you have the 3mm one? Ah, beautiful. Let me show you this. So grab this please here. I want to show you one of the great things about this micro. This is a short micro. It's incredibly useful when you're doing transpedal because this is more than you need for a tibial length. And it makes your procedures much more easier when you're dealing with a short table. So as you saw before, there's a lot of catheter hanging around. And right now it's great because we have a very short catheter but very efficient for what we need. So go ahead and load that up. Ahí está. Halo? Halo guía. Halo guía. Perfecto. Alright, so we're going to go live again. Tiene la guía up through the transpedal sheath, up with a 3mm balloon. All the way up to where we want it, to that center balloon. And again, negativo. Sacan el aire para afuera. Ok. Negativo otra vez. Here's para arriba. So let's go slowly up. There you go. Now you start seeing a little bit better balloon contour. I think the 2 was certainly very undersized, but I think this one makes more sense. And you are at 8 atmospheres. And that's exactly what we needed. So recapping number 1, a very good duplex that allows you the certainty that by accessing here you're not leaving disease distal. 2, judicious ultrasound guided access, making sure it's luminal, that you have good blood return, and that you put the valve in the right way. 3, get a good wire. Hydro SD is a phenomenal wire for this sort of work. 4, know how to maneuver that wire. Make sure that you're always in the lumen. And then 5, utilizing a micro 14, you remain still very small on the sheath side because you're doing it all through the transpedal, and no other balloon is actually going to go through this as easily as that. And then hopefully here soon we can give you a nice angiogram. We'll have to put obviously a little microcatheter and do an angiogram from the top and then plow it all the way down. And by the end we'll pull the pedal sheath and we'll hold some pressure there, either ultrasound guided or simply with a radial band. Normally those, of course, those patients go home within approximately 1 to 2 hours after the procedure. We just make sure hemostasis is completed. Vamos para abajo. Ahí, gracias. So let's go ahead and move that balloon down. Right there. And you do have to sometimes pull the sheath back, because that sheath, will be a few centimeters into the artery, so you got to be judicious that you need to pull it off, backwards. That's perfect. And here what I'll do is I'm going to focus on the axis side. Abajo. Zoom. No. Ahí. Para abajo. Más abajo. Ahí. Gracias. And here what I'm going to do is I'm going to do a quick little angiogram. The balloon may be occlusive, so this may not necessarily work, but I think so. We have enough flow here. I'm just going to do a little trickle. The idea is to see if I need to pull that back a little bit more. And I do believe that we are right where there's a little lesion that has to come back a little bit more. So we're going to go ahead and pull that catheter a little bit more and knock that one lesion that's right below us. And then hopefully with that we should be done. It's been great to meet you. Welcome to Mexico. All right, negative. Play el pasado. Let's play the last one. Ah, ahí está perfecto. Okay. No, I got it. I saw the reference image already. It's okay. We're right at it. A little more. There you go. Beautiful. Store that. Thank you. So I did pull, I want you to go into the GoPro and take a look down here. I did pull the sheath a little bit far back so that we could hit right down into that area. And to make sure that it wasn't putting the vessel at any risk, I pulled back into the angiogram, got my marks, and then pulled back safely, okay? So what I'll do here in a bit is once he deflates the balloon, I'm going to advance the sheath again, and then we're going to put a little catheter to get a quick shot. Quítale el zoom y vamos para arriba, fuera zoom.
Vamos a la oblitea.
Oblitea, fuera zoom. Voy. So I just used the same micro 14 balloon. I'm going to use the internal. If you look downwards at the table, I'm using the inner lumen for the wire to inject. If I don't get a great image, this is an 014 lumen, I can put a CXI and do, an 018 lumen to inject a little bit more. I can also inject from the pedal sheath. So let's see what this looks like. So injecting, nice contrast, beautiful looking AT proximally. Okay, let's go distal, vamos abajo. It is not rare that you need to open the valve a little bit to give yourself a better image. Centra los huesos, abre la colimación un poquito. Centre, oh, para el otro lado. Ahí, perfect. Let's take a look at this area. Injecting. And you see that AT looks very beautiful all the way down. No significant dissections. Para abajo. Mamás. And I'm going to do the same here one more time. And as you see, I'm using this catheter to allow me to get the images I need. To me, that looks great. That anterior tibial looks beautiful all the way down. I feel very confident that I can pull that catheter out. And I'm going to go back in. I also want to show you here, not to do this on an irresponsible way, but look at how beautiful the flow is now through this AT. I mean, that is as pulsatile as you can get it. And I'm very confident that now we have good flow. Before it was really just a trickle flow we were getting there. Hazme una lateral de pie. We're going to get a nice lateral foot view here. I hope you've learned a little bit of endo and a little bit of Spanish today. Colimación, toda abierta, full. Ahí está bien. Y luego hacemos otra toma. So very beautiful. Okay. Vamos ahora abajo, al pie.
Más pie, más dedo.
Un poquitín más de contraste.
Ahí.
Un poquito más de dedos. Get those toes. There you go. And this is what I call the money shot, because we really want to see that there's good flow through that pedal loop, and that we may just need the anterior circulation for this case. So let's see what it looks like. See, that's a beautiful AT down to the DP and almost retrograde, and you almost see wound blush into the segment of the open plantar wound. So I feel very confident that this patient is going to do well. What we're going to do here next is we're going to take that sheath out and just hold a little pressure. And actually I can come back and show you, once we have all that done, I'll show you some pedal acceleration time, and that should show us how we have beautiful perfusion on the dorsalis pedis, something that we've been doing more and more, and it helps us take a decision. Do I need a little bit more, or do I not need a little bit more? And I would be sure that you could have a great waveform at this point in the case. So anyway, thanks for being here, Dr. Munoz. Thank you very much for letting us, and welcome to you and everybody around the world to Mexico. Dr. Gonzalez, it's a pleasure to have you here. Thank you. Have fun.